medical misinformation is everywhere. Dr. Mitch is here for straight talk and to give you the truth.
This is the final installment on our testosterone primer. And today we're going to look at pretty much treatments options that are available. Now, first, let's take a look at the types and delivery options available to us as clinicians, of course. There is an oral method, topical creams, injection, pellets, and for some women even, there are vaginal applications as well. So let's start with the injectable. Now, the injectable is a synthetic testosterone, which belongs to really the first attempt of our making testosterone. This was probably back in the early 1940s. The method is not bioidentical and requires the first pass liver detoxification pathways. In addition, although similar to our endogenous testosterone, it can be seen by the immune system as foreign. Imagine it looks similar, but just a slight change may make the immune system hyper. And of course, there's so much autoimmune disease, we have to consider that. I would limit this form since it is liver irritating and it can occasionally cause some serious side effects. The duration of this form is about 3 weeks, but after about a week and a half, it begins to lose its effectiveness and the folks are looking for another shot. Now, creams are bioidentical, but they must be used daily. They have to be rubbed into fatty areas at different sites, like under the arm or in the belly or in the inner thighs, and every day move it around. There are 20% of folks that are unable to use or to get respectable, sustainable levels using a topical type of testosterone. Similarly, the vaginal application may have the same problem and not reach optimal levels, or it could cause vaginal irritation. Often that's dependent upon the carrier which the compounding pharmacist puts it in. Now, oral testosterone is inevitably synthetic and it's irritating to the liver. Now, occasional use prior to sex in some instances may augment the patient's experience, but for the most part, it should never be a method of giving testosterone regularly. Pellets are bioidentical. They're the only method that represents zero-order kinetics. They release smoothly throughout the day, throughout the night, at about 0.5 milligram per pellet a day. Their typical life is about 200 days for a 100 milligram pellet, and that's, by the way, regardless of how many pellets are placed. So don't think if you place more pellets, it lasts longer. The same kinetics are going to be there. Now, even though they will continue to release for 200 days, patients may require reinsertion earlier because you created with the pellets a new benchmark. For example, studies have shown this to be correct. If a man starts at 200 nanograms per deciliter, you take it up with pellets to, for example, 1,000, sometimes and often by the time they reach 600, they just don't feel it anymore. Now, dosing should be done based on the patient's history and lab evaluation. Now, be aware, the testicles, when they're youthful and healthy, they produce levels of 6 to 9 milligrams per day, and a woman's ovaries typically produce 1.5 to 1 milligram a day. So make your choice of quantity or the amount in any of these methods based upon the outcome you're seeking. It's also incumbent on you, in my opinion, that you ensure that your patient is given either a baby aspirin if possible or a natural antifibrinolytic agent to keep the potential of early use testosterone from causing an increase in blood viscosity. I'm also going to suggest very strongly use a natural product that blocks the alpha-5 reductase pathway to DHT, dihydrotestosterone, and encourages the 2-hydroxyestrone non-proliferative pathway. Check the patient's levels of blood in a month and again in 3 months after the initiation of treatment. Adjust the doses accordingly, of course. And last but not least, pretty much get in men a baseline of a PSA and women a mammogram of the breast or an ultrasound. Get a fibrinogen blood test pretty much in both. Good to have a CBC as well as a complete metabolic profile. And somewhere along the line, if it's an elderly female, I would get a pelvic ultrasound both transabdominally and intravaginally. I'm Dr. Mitch Ghen, and I hope you've enjoyed this series. And if you have any further questions or need help, please feel free to contact me at drmitchghen.com. That's DrMitchGhen.com.